let me tell you about my patient, Margaret. 71 years old, sharp as a tack, retired school teacher, walks 2 miles every morning, and takes care of her garden on weekends. She came into my office one afternoon not because she was sick, but because her neighbor had scared her half to death. Her neighbor had gone in for a routine checkup, and what followed was a cascade of tests, referrals, biopsies, and procedures that stretched over 8 months. Margaret's neighbor lost 30 pounds from stress, anxiety, and the side effects of a procedure she never needed. She was fine. She had always been fine. The doctors were chasing a number on a lab report, not a disease that was hurting her. That story is not rare. That story is happening every single day in clinics and hospitals across this country, and it is happening to people just like you. I'm Dr. Jennifer High, and I have spent over 2 decades in internal medicine and preventive care. I love medicine. I believe in medicine. But I also believe that medicine, when applied without wisdom, can cause more harm than good, especially after the age of 65. There is a phrase we use in medical school that most doctors quietly forget by the time they are billing for their fourth test of the morning. First, do no harm. Here is the uncomfortable truth that no one tells you at your annual physical. More testing does not always mean better health outcomes. After the age of 65, certain screenings that were once considered standard of care can actually lead to unnecessary surgeries, dangerous complications, crippling anxiety, and a dramatically reduced quality of life, all without adding a single meaningful year to your lifespan. I'm not here to tell you to skip your doctor's appointments. Please don't do that. What I am here to tell you is that you deserve to walk into that office informed. You deserve to ask questions. You deserve to understand that the person handing you a referral slip is working from guidelines that may not account for your age, your overall health, or your personal values. Today, I am going to walk you through 5 common medical checkups and screenings that I personally would not get and would not recommend to my own family members after the age of 65. Some of these are going to surprise you. Some of them might even frustrate you. But by the end of this, you will have a framework for thinking about your own healthcare that no one else is giving you. Let's talk about what routine really costs. Part 1. Routine full-body CT scans. Every few years, a new wave of direct-to-consumer imaging centers pops up offering something that sounds incredibly appealing, a full-body CT scan. The pitch is seductive. See everything going on inside your body. Catch cancer before it starts. Peace of mind for life. Let me tell you what they don't put in the brochure. A full-body CT scan delivers a significant dose of radiation, roughly equivalent to 300 chest X-rays in a single session. For a 65-year-old person, repeated exposure to that level of radiation is not a trivial concern. But here is the part that really keeps me up at night: the incidentaloma problem. When you scan the entire body of a healthy 65-year-old, you will find something. Not because something is wrong, but because bodies are not factory-perfect machines. They have tiny cysts on the kidneys, small nodules on the lungs, calcifications on the liver, adrenal gland irregularities. The vast majority of these findings are completely benign and will never cause a single day of illness. But once you find them, you cannot unfind them. And medicine has a hard time walking away from a finding on an image. I had a patient named Harold, 74 years old, healthy, retired electrician. He paid out of pocket for a full-body scan at one of these boutique imaging centers. The report came back with a 7-millimeter lung nodule, completely incidental. The radiologist even noted it was likely benign. But Harold's primary care doctor referred him to a pulmonologist. The pulmonologist ordered a follow-up CT 3 months later, then another, then a PET scan, then a biopsy, which punctured Harold's lung and caused a partial collapse requiring a chest tube and a 3-day hospital stay. The nodule was nothing. Harold spent 11 months terrified, underwent a procedure with serious risks, and came out the other side with hospital bills that exceeded $15,000. The nodule never grew. It never caused him a single symptom. He had been perfectly healthy the entire time. Full-body CT scans are not approved or recommended by any major medical organization for routine screening in adults. The American College of Radiology has explicitly stated they do not endorse them. After 65, the combination of radiation exposure, high false positive rates, and the cascade of interventions that follow makes this a screening I would never subject myself to. Part 2. Routine. Pelvic exams for women who are not sexually active and have no symptoms. This one is going to be controversial, but I want you to hear me out. The annual pelvic exam has been a cornerstone of women's healthcare for generations. And for the right woman in the right context, absolutely, it has value. Pap smears, for instance, are critical for detecting cervical cancer. But here is something that was updated in guidelines that many practitioners still haven't caught up with. The United States Preventive Services Task Force, the American College of Physicians, and the American College of Obstetrics and Gynecology have all moved away from recommending routine annual pelvic exams for asymptomatic women, especially women over 65 who are not sexually active and who have had normal pap smears consistently. After 65, most women who have had 3 consecutive normal pap smears within the past 10 years, with the most recent one being within the last 5 years, can stop cervical cancer screening entirely. The cervical cancer risk at that point is extraordinarily low, and the benefits of continued screening do not outweigh the harms. False positives, anxiety, painful follow-up colposcopies, and biopsies of tissue that would never have caused harm. A patient of mine, 68 years old, widowed, not sexually active, was still getting annual pelvic exams and pap smears. One year, the pap came back with a slightly abnormal result that was almost certainly related to normal hormonal changes after menopause, not cancer. But the protocol triggered a colposcopy, then a biopsy. The biopsy was negative. But the anxiety she experienced in those 4 weeks between results, combined with the physical discomfort of the procedure, was genuinely traumatic for her. She told me afterward she wished she had never done the test. I want to be absolutely clear. If you have symptoms, unusual bleeding, discharge, pain, you see your doctor immediately. And if you are sexually active and at risk, screenings remain important. But routine pelvic exams for asymptomatic older women who are past their screening window, that conversation deserves to happen honestly between you and your physician, with your specific history guiding the decision. Part 3. Aggressive cardiac stress testing without symptoms. Here is where I know I am going to get pushback from some of my cardiology colleagues, and I respect that disagreement, but I want to share what the evidence actually says. Cardiac stress tests, particularly nuclear stress tests and stress echocardiograms, are powerful, valuable diagnostic tools when used correctly. If you have chest pain, if you have shortness of breath on exertion, if you have risk factors that are escalating rapidly, in those scenarios, I am sending you for a stress test without hesitation. But routine stress testing on an asymptomatic 65-plus-year-old simply because it's good to check? The evidence does not support it. The American Heart Association, the American College of Cardiology, and the U.S. Preventive Services Task Force all explicitly state that routine cardiac screening with exercise testing in low-risk asymptomatic adults does not reduce cardiovascular mortality. What it does do is generate a significant number of false positives. Think about what a false positive in cardiology looks like. You come in feeling fine. The stress test shows something that looks possibly abnormal. Now you're referred for a cardiac catheterization, a procedure where a thin tube is threaded through your arteries. Serious complications, including heart attack and stroke, occur in approximately 1 in 1,000 catheterizations. And if you are 65 or older, your baseline risk of those complications is higher. Studies have estimated that for every 10,000 asymptomatic patients screened with a stress test, the number who benefit is genuinely small, while a meaningful number experience harm from the cascade of procedures that follow. Think about my patient, Frank. 67, a little overweight, but asymptomatic. His internist ordered a nuclear stress test as part of a senior wellness package. The test showed a slightly abnormal perfusion pattern. He was referred for catheterization. The catheterization showed mild coronary artery disease, the kind that was being perfectly managed with his statin and aspirin. But the interventional cardiologist felt compelled to place a stent. Frank developed a clot post-procedure, had a small heart attack, and spent 5 days in the cardiac ICU. He went in healthy and came out as a cardiac patient because of a test he never needed. After 65, I want you to know your risk factors. I want you to manage your blood pressure, your cholesterol, your diabetes. I want you active, eating well, not smoking. But a routine stress test because you hit a certain birthday? That is a conversation I would push back on very hard. Part 4. Prostate-specific antigen testing beyond a certain point. PS. A testing, the blood test used to screen for prostate cancer, is one of the most debated topics in all of medicine. And for men over 65, that debate has largely been settled in a direction that many patients and doctors are still not following. The U.S. Preventive Services Task Force currently recommends against PSA screening for men 70 and older. The American Cancer Society and major urological organizations have drawn similar lines, noting that the potential harms of PSA testing in older men substantially outweigh the benefits. Here is why. Prostate cancer is extraordinarily common in older men. Autopsy studies have shown that up to 80% of men in their 80s have some prostate cancer cells present in their bodies. The vast majority of these cancers are what we call clinically insignificant. They are slow growing, they are not going anywhere, and they will never cause symptoms or shorten a man's life. Men with these cancers die with prostate cancer, not from it. But when you screen with PSA and you find one of these cancers, the current system is poorly equipped to let it alone. Men receive diagnoses. Diagnoses lead to fear. Fear leads to treatment. And treatment for prostate cancer, whether radiation, surgery, or hormone therapy, carries serious risks of urinary incontinence, erectile dysfunction, bowel problems, and cardiovascular side effects that significantly damage quality of life. A large European study called the ERSPC trial and the American PLCO trial both found that for older men, PSA screening did not reduce prostate cancer mortality in a meaningful way, but it did result in substantial overdiagnosis and overtreatment. My patient George was 72, perfectly healthy, active, playing tennis twice a week. His PSA came back elevated. The biopsy confirmed a low-grade prostate cancer. His urologist recommended surgery. George had the surgery. He never had incontinence before the surgery. He had it every day for the rest of his life afterward. He came to see me 6 months post-op and told me quietly that he felt the surgery had taken something from him that no one had warned him about. The cancer almost certainly would have caused him zero harm if it had simply been watched. For men over 65, and especially over 70, this is a conversation to have with your doctor honestly and thoughtfully, weighing your personal health, your family history, and your values. Routine PSA testing simply to check is something I would not do. Part 5. Routine. Colonoscopies after 80. I want to be careful here because colonoscopies save lives. They genuinely do. Colorectal cancer is the second leading cause of cancer death in America, and colonoscopy is one of our most powerful tools against it. But like every powerful tool, the question is not simply, does it work? The question is, does it work for this person at this stage of their life, given the balance of risks and benefits? The American Cancer Society recommends that colorectal cancer screening decisions after 75 be individualized, and that after 85, routine screening is generally not recommended. The reasoning is not that older people don't matter. The reasoning is mathematical and biological. Colorectal cancer typically takes 10 to 15 years from the formation of a polyp to develop into an invasive cancer. If you are 80 years old and a small polyp is found, the statistical likelihood that this polyp would ever cause you harm within your remaining lifespan is very low. Meanwhile, the risks of colonoscopy, which require sedation, bowel prep, and physical scope insertion, are meaningfully higher in older adults. Perforation rates, post-procedure bleeding, and anesthesia complications all increase with age. For a patient in their mid-80s or beyond, the bowel prep itself can cause dangerous dehydration and electrolyte imbalances. I had a patient, 82 years old, named Dorothy. Sharp, lively, still teaching piano lessons. Her daughter insisted she get a colonoscopy because it's been 5 years. During the procedure, a small polyp was removed and the colon perforated. Dorothy required emergency surgery, spent 2 weeks in the hospital, developed pneumonia, and never fully regained her previous level of functioning. She went in for a routine screening and came out needing a walker. The colonoscopy found a benign polyp that would almost certainly never have harmed her. The procedure that removed it very likely shortened and diminished her life. After 80, and in many cases after 75, depending on overall health and prior screening history, this is a decision that should be made with extreme care, not simply because it is on a checklist. I want to close with something I say to every patient I truly care about. Medicine is not the same as health, tests are not the same as answers, and a longer list of diagnoses is not the same as a longer, better life. The system we have built, for all its brilliance and innovation, has a structural incentive toward doing more. More tests, more procedures, more follow-ups, more referrals. For many years and many conditions, more is exactly the right answer. But after 65, when the body carries more complexity and the stakes of intervention are higher, more can become the enemy of good. What I want for you, what I want for my own patients, my own parents, myself, is medicine that is thoughtful, personalized, and honest. A doctor who sits with you and says, here is the benefit of this test. Here is the risk. Here is what the evidence says for someone your age, with your health history, living your life. What matters most to you? That is the kind of medicine that actually heals. You are not a number on a lab result. You are not a billing code. You are a person who has built a life, and the goal of medicine at your stage should not be to find every imperfection hiding in your biology. It should be to protect the quality and the joy of the years you have left. So the next time a doctor recommends a test, I want you to feel empowered to ask 3 simple questions. What will this test tell us? What will we do differently based on the result? And what are the risks if we find something? If the answers are vague, or if the cascade of potential consequences outweighs the likely benefit, you have every right to say, let me think about this. Let me ask a second opinion. Let me decide what is right for me. I'm Dr. Jennifer High. I got into medicine because I want people to live better, not just longer. And sometimes the most powerful prescription I can write is this: be informed, be your own advocate, and remember that doing nothing is also a valid medical decision. Take care of yourselves and take care of each other.